Hi, everyone. Thank you for joining us this evening. I am excited to be here. My name is Madeline Bizocco, one of the senior directors with Neurosignal, and I'm excited about this webinar that we have coming up tonight. I will be your host, so excited to be here. The name of our webinar is Empowering Growth with Robotic TCD, Contributions to a Robust Comprehensive Stroke Center. So I'll be introducing you to some great people this evening who I've had a pleasure of working with over the past couple of years. So very excited to have everyone. I'm going to wait a couple minutes for some more folks to join. But please feel free to comment what city you're watching from. Love to hear where everybody's at. I'm from rainy New York this evening. It is super dreary and rainy, so I hope some people are from a sunnier part of the world right now. But so happy to have everyone and excited about the webinar for this evening. And the two folks that will actually be joining us are from South Shore University Hospital, part of one of the largest IDNs in the Northeast, a part of Northwell. So excited, especially with Neurosignal. We've got systems all throughout that IDN, which has been great with expansion and growth and increasing numbers for both cardio and neuro. So we'll be hearing more about the neuro side this evening, but also about bridging that gap between cardio and neuro and how that brain-heart relationship connects. So excited to talk about that too. Awesome. I see Matt Earhart's watching from New York as well. I know it's super rainy there, so thank you for joining. Hi, Lindsay from LA, probably warmer and sunnier over there, I hope, a little earlier in the day than us. Hi, Mazin, Dr. Khatib, I apologize, watching from San Diego, also from warmer weathers. Hi, Dan, watching from Arizona, definitely hot out there. Hi, Eric, watching from Los Angeles. Awesome. Got folks coming from all over. Really appreciate you guys joining this evening or during the afternoon. Evening for me, but afternoon for you guys. Perfect. So the two speakers that we'll be having this evening, I've had the pleasure of working with for the past couple of years. Wonderful people. So both Dr. Krista Limhing and David Lugo, the registered EEG check from South Shore, are going to be joining us. Dr. Limhing is the Director of Neurosciences in the intensive care unit for South Shore, part of Northwell that I mentioned before, a board certified neurologist, neurointensivist, specializes in neurostroke and neurocritical care. Dr. Limhing is super passionate about integrating innovative technologies into stroke workflows. Had the pleasure of helping her with that, so fortunate. During this webinar, she will be sharing South Shore University Hospital's experience with implementing the NG2 intelligent ultrasound and the impact that it's had on their stroke and PFO workflow. So really excited about hearing from Krista this evening. Dr. David Lugo, registered EEG tech. He's also from South Shore, part of Northwell. He supports the comprehensive stroke program through advanced neurodiagnostic testing and transcranial Doppler, TCD, using our device in inpatient and outpatient. As an experienced user of TCD, David has played a key role in integrating robotic TCD into daily clinical practice. So excited to hear from David too. We have both end users, which is really exciting for this evening. So to get two different perspectives, which would be really great. All right, so let's bring them on stage. That would be wonderful. And I will be able to share my screen. Hi, Krista. Hi, David. So nice to see you both.
Hi there.
Hi.
Good to see you, Maddie.
Thank you guys so much for joining us this evening. We so appreciate you guys taking time out of your busy week and work day to join us. I'm going to share my screen for you guys and then just tell me to click through whenever you guys want me to go to the next screen or the next slide. Give me just 1 second. Perfect. Can you guys see my screen?
Not yet. Oh, there it is. Just a little delayed. It must be the
perfect. Perfect. It's got to be the weather. It's got to be the weather in the Northeast. Wonderful. I'm so glad. Well, thank you guys again so much for joining us, and we really appreciate your time. So excited to hear about the Empowering Growth Robotic TCD contributions to the robust comprehensive stroke center at the University Hospital. I'll kick it over to you guys, and like I said, just instruct me, and I will go through the slides for you.
So thank you so much for that lovely introduction. And we are just thrilled to be here as well to share our experience. You've really been a key part of our growth pretty much from the beginning of when I had started in this position. So this is really a relatable topic, I think, to a lot of people who may not be starting at the most resource-laden academic centers where you're really having to grow and build something over time and sometimes starting from scratch. So that's why we chose this topic to discuss, because we really feel that it's relatable and will hopefully give a bit of a roadmap and food for thought on next steps and your own experiences. Next slide, please. So our agenda for our talk this evening is to give you a picture of how we experienced incorporating the NG2 into our program growth. We'll talk a little bit about the past with our TCD training and the overall program growth, the present, what we're doing currently with our model, and how we're utilizing and implementing different workflows, and then our future plans and hopes for the program growth in the near future. Next slide, please. So our program started in 2019 when our community hospital was deciding to expand its neurosciences program. And I know this is likely a classic story. There's really a boom in the neurosciences right now. We were a community hospital and have now become a tertiary hospital in the region over the last 7 years. But at the time, there was no primary stroke service. There was no neuro ICU. The neurosurgery service was mostly consulting, and there definitely weren't any thrombectomies being done or neuro IR at the moment. So it was the very definition of your classic community hospital. Next slide, please. In looking at the challenges that we faced in building this program and the vision that we had for the resources and the treatments and the medical care that we were hoping to offer our community in our region, there was a lot that really needed to be added to our program and to our site in general. The education was a huge lift when you're talking about most patients boarding in a medical ICU or a general medical floor. The ED is very accustomed to sending brain bleeds out of the hospital, and subarachnoid hemorrhages definitely aren't staying with us. So there was a lot of education and training and adjustment and general mindset change that needed to happen. We did have EEG, but it was not 24/7. And so many times, like status epilepticus and those more advanced diagnoses were sent out. And then, of course, our technicians weren't hired yet. And so in general, it's taking the mindset of transitioning from a community hospital to a tertiary center and a specialty center that is offering all of these things. And in the midst of that, you might note that 2019 went into 2020, which turned into 2020 and 2021, which was dominated by COVID. So that also put a little bit of a dent in our progress, but we came out fine the other side. So I'll pass this over to David and tell you a little bit about the resources and how the staff grew from the technicians and the other specialists in our department.
Sure. Thank you, Krista. So at that point, 4 TCDs Specifically, we had a tech from a sister hospital coming out whenever she was available to perform TCDs. I think it was sometimes once, maybe twice a week when she could, which meant there wasn't a lot of room for growth in that area. Um, as well, even for EEG, it was just getting having enough staff to just to say get that 24/7 coverage. Since then, we've been able to increase coverage on both those areas. And part of that was incorporating the robotic TCD, which allowed us to bring in um, essentially novices and myself to TCD and quickly train and equip them to perform these tests. And to that point, I'll talk a little bit about the training. Next slide, please. So for me, I was coming into this having never done TCDs before. I had only kind of seen them done in the past. I have a background in EEG. I've been doing this for about 10 years, so I had knowledge of anatomy of the brain, but uh, a new test was, still something I had to learn. Um, Realistically, it was a boot camp essentially. I had a week to learn, and Andrew over at Neurosignal was extremely helpful, and we were able to get it done uh, quicker than we expected, actually. So my training looked like this. Kind of the first day was just kind of learning what TCD was, flow rates, directions, like what to expect when I'm looking at a TCD. Basically, just the basics. Day two, we immediately jumped into learning the use of the actual robotic TCD machine. Um, Learning how to start studies, manipulate the probes and software, do the physical setup, um, and then the editing, the post editing of TCDs in the software. Day three, we were already setting up TCDs on each other. He would put it on me just so I understood um, the process of setting it up, and then have me run practice tests on him to get the learning physically. By day four, we were live. This was, 12 hours into my education. I set up my first patient that Thursday with Andrew's support, obviously, but uh, we were ready to go within a few days, which is a stark contrast to what it would take to have uh, trained on manual TCDs. So being able to get that training done within a week made it so that uh, I could still handle my duties in EEG, but get the education I needed to start performing TCDs for the hospital. Next slide. Uh, I'll hand it off to Kristen for this.
So that was probably around 2020, 2021 that we were getting our TCD program going. And after our sister hospital had shared our Stacy, who's our TCD tech, or I would say the pro in the region who has decades of manual TCD experience, but in the hiring process and in finding the practicality of resources and training someone, you can't expedite experience really. So the having the NG2 and having David willing to learn this new skill was just paramount in moving forward with our ability to properly care for subarachnoid hemorrhages and move forward in the other management fields such as stroke and really bridging that gap with the cardiac component of stroke assessment. So 2026, we've made it to being a full-fledged tertiary academic center. Residents and medical students rotate regularly. We have a primary stroke service with an average of 8 primary patients and many other consulting patients on various other services. They have an average of 6 consults and 4 stroke codes in the hospital on a daily basis. We also have a primary neurosciences ICU with 8 designated geographic beds, but oftentimes overflowing into the other ICUs with boarders. We to give you an idea, January to July, we only had about 7 subarachnoid hemorrhages this year. So not an overwhelmingly abundant number of subarachnoids, but as our hospital and our neurosciences service is growing, this seems to be escalating over the last few years as well. And we have been designated as an advanced comprehensive stroke center, and in 2025 had done 75 thrombectomies. And from considering 2020, we were just starting to do thrombectomies, it's really been a pleasant growth and surprisingly smooth experience despite COVID. Next slide, please.
And this is just to demonstrate our ability to perform the TCDs as well as the growth of the program over the last few years. Before 2023, when we got the NG2, we were really only getting between 20 and 40 TCDs performed per year, both because the service wasn't really there and also because we didn't have the staff to perform them. Once we were up and running with the NG2, we immediately skyrocketed, and now we're doing well over 200 cases a year generally since 2024. Next slide. So I just wanted to talk about a little bit about the day-to-day experience of using the NG2 as well as working with NeuroSignal. So I broke it down a little bit. Hardware, really it's a very easy to use machine. The setup is simple and easy, very repeatable. It's reliable, and it definitely lowers the barrier of entry for reliable TCD monitoring, as well as in my specific case. As Chris has said, we've only had 7 subarachnoid cases this year, so occasionally we can go weeks or months without seeing a TCD case. It's very easy to return to after a hiatus, as far as not losing the skill of setting up the machine and working with the probes. On the software side of the machine, it's very intuitive. It's also quite beginner friendly, but it still gives you all of the ability to manipulate the study as you need. The probes can be moved wherever you need to help find windows, as well as the post-processing of those images is just as feature-rich as any other machine out there, as well as the software and NovaGuide View, which is it's an app, and it allows for remote monitoring of TCDs, which both allows our doctors to live view our TCDs, as well as allow us in the field to get support from NeuroSignal should we need to. I can think of an example of early on in my TCD career. I had an issue with a patient where the flow was not necessarily what I was expecting. It appeared to be an inverted flow in a place where I was expecting something different. So I reached out to Andrew from NeuroSignal. He was able to remote in with the NovaGuide View app and kind of coach me along to it ended up being something that was not abnormal, but I hadn't seen it yet. But he coached me through it. So it was very, very helpful to have that NovaGuide View. Next slide.
So where we're going, this is the next steps and what we're hoping to implement and give David more hands-on with TCDs and add more studies and more application to it. Right now, I think the EEGs tend to dominate your day, but we have a lot of things planned for TCD now that we've established some of the other protocols. So one of the things is having providers step in also during the times that our sonographers may not be able to be available, especially like the summer months when people are on vacation or might want to go to Disney Paris or something. So we've had to have some backup plans in case we run into those situations and we have a subarachnoid who we desperately want the TCDs to be done on. So, or sometimes weekends, it's tight staffing as well. So that's one thing that when Andrew and Maddie and the NeuroSignal team came through, they were able to train some of our providers who, again, as David had mentioned, we wouldn't be doing it on a daily basis or even a weekly basis, but the logical ease of use and the kind of riding a bike type of feel for it is very helpful. And so once we learned the gist of setting up the probes and were able to perform some studies on each other, it was comforting to know that we would have a backup plan if our two sonographers were not able to be present on the unit. We also want to incorporate our TCD with microbubble workflow, which we've intermittently been using on select patients, but we, in partnership with the stroke neurologists and our cardiologists, would definitely like to expand upon that. And I'll talk a little bit more about that workflow if some of you haven't been as familiar with this fairly fresh addition to the stroke workup. And then the post-mechanical thrombectomy monitoring is also a thought of the rogue emboli that might be residual and causing additional strokes, to monitor that way. And possibly, which this is much further down the line, but the perioperative monitoring with our CT surgery colleagues, or possibly the cardiac intervention side, which we know both sets will occasionally call code strokes. And then this would just put you ahead of the game. If you were suspecting a risky thrombus or plaque to possibly cause some stroke-like symptoms or stroke burden, to already have this hooked up would be an amazing addition. And I know there are a few centers in the country that have been able to achieve this partnership, and I think it's just would be a fantastic move. And next slide, please. So this is one depiction of a great infographic. So basically referring to the right to left shunt that you're detecting with the microbubbles. So that is usually in about 10% of the ischemic strokes in young and middle-aged adults. And so the most utility for this has been in the under 60-year-olds. Greater than 60 still to be seen, but there is the right to left shunt phenomenon, which could be intracardiac or like through a PFO or ASD, or it could, in a rarer sense, be such as a pulmonary AVM. But the bubble test is great because it is non-invasive and it's actually more sensitive and specific than a TEE, and of course also more sensitive and specific than a transthoracic echo. So next slide, please. So this is the general management of thought for PFO closure and secondary stroke prevention. I know there's been a lot of disagreement or controversy surrounding whether or not we should even close a PFO, but in some of the more recent studies, it's becoming more accepted as a standard of care and recommendation to reduce the stroke burden. So the typical diagnoses would be an echo or TCDs. You also could do cardiac CT or MRI to diagnose the PFO. And then it has been shown in 6 clinical trials that PFO closure does in fact benefit those less than 60 years of age. But there are still some knowledge gaps and a lot of room for improvement in that field of who actually would benefit from PFO closure. And next slide, please. So this is the workflow that we're keen on implementing at our site with ischemic stroke. And currently we typically do a basic stroke workup of everyone gets a transthoracic echo And then many times cardiology will recommend a TEE if they're young and don't have, or even if the PFO was not found on TTE. So that's where the variation comes in this workflow, is where the embolic stroke of undetermined source would be in someone less than 60 years of age. You would still get a TTE and then decide whether or not if you should get a TCD with bubble, and or if you should get a TEE or go directly to TEE. But this utilization of TCD with microbubble allows you to have the non-invasive, no anesthesia, no esophageal entry to detect these PFOs, and it may prevent some or help prevent someone from not having to have a TEE if they in fact still don't have a PFO detected on the TCD with bubble. You can skip the TEE. And then there would be the next steps of deciding what to do with this information. And so if the PFO is present and they're less than 60, and then you go through the Pascal index or classification, and then whether or not the stroke was likely to have come from the PFO, and if they should in fact be closed or have a PFO closure. So we're really going to work with our cardiac colleagues and our stroke service and work through a unified and consistent use of this workflow. But they're exciting things because we really have used the TCDs standardly for our vasospasm monitoring at this point with subarachnoid hemorrhages, and even had a couple of later other like TBIs and other concerns for vasospasm evaluating with their TCDs. And we have done some use with the micro bubbles, and then a few instances of the post IR operative monitoring. And then David had done a few brain death studies as well for ancillary tests. But we're still working on broadening our use of it. But I would say in general, having David be as proficient as he is and his colleague being as proficient as she is with the NG2, we couldn't have gotten to where we are if we were searching for someone with the manual experience and having to learn from scratch. It just wouldn't have been practical in our situation of building this program. So next slide, please.
Sure. So in conclusion, building a comprehensive stroke center is resource intensive and requires a lot of education. And uh, using the robotic TCD has allowed us to streamline that process and provide quality TCDs and optimize, as well as optimize our stroke care uh, a lot quicker than probably would have been possible otherwise. As Chris was mentioning, the training for a manual TCD requires significantly more time than we had to get our program up and running. So this allowed us to start that without too much trouble.
And so that concludes our presentation.
Thank you guys. Thank you guys so much. I'm going to stop sharing my screen for you. No, thank you guys again for your time. And it's so nice to hear too how you can start out with one exam type and you can expand from there. Obviously with working with different groups, David, we're so lucky to work with you being the end user, you and also, your partner in crime and Krista being able to work with you guys, how engaged you are, how much you guys want to change the stroke workflow, and just, better patient care, which is what we're all, so passionate about. So No, that was wonderful. I do have a couple of questions for you guys that trickled in, and then would love to dive into the chat too. Dr. Lim Hang, when you first considered implementing robotic TCD, what clinical or operational challenges were you hoping to solve, and has the technology met those expectations for you?
So the clinical and operational challenges were definitely the resources, and both from a experience-based training perspective, and hiring a full-time like 1.0, or it would end up having to be 2.0, 2.5 FTE to cover all the time of if someone was truly a dedicated TCD sonographer, and our resources wouldn't allow that. The other logistical problems, I would say, we were fortunate to have David and his partner is split with radiology. So both of our sonographers are dual trained in a sense, and multifunctional in that they can pick up the TCDs when we have the influx of those patients. But as we all know, with subarachnoids, they come and go in boluses, and so there can be times where there's no TCDs to be done. So we don't want our TCD techs to not have anything to do in that time. So it's really been a benefit, especially to our size of program, in that we're not doing the TCDs all day, every day, like Andrew is, where I think he's just constantly doing TCDs, or he was. And so this just fit our situation very well. And then the software, it does incorporate components of AI and interpretation, and kind of producing the reports, and the way the robot finds the MCA. And it was a little sci-fi to me at first. I was a little apprehensive of and seeing the model, and I had been to some conferences where you guys were at the conference doing demos and things, and
Sure.
it's a little sci-fi. Looking at the robot on someone's head, and especially when I do have friends that are very passionate about the manual TCDs, and that it's an art, and I do still have an appreciation for that. And for those who are highly trained and experienced and have the thousands of hours that make you an expert, but in our growing program, we needed something reliable and consistent and efficient and proficient for giving us good reports and reliable answers for our patients.
Of course. And just to piggyback off of what you were saying as well, our goal is to never replace anyone. Our goal is always to give novice users, who, including myself prior to being trained, a tool to be able to get accurate information to physicians like yourself that can help the patient. So just giving you guys those tools to be able to lead to a comprehensive stroke center, lead to getting more proficient results, more accurate results Monday through Sunday, and having no lulls in TCD. And I know that you guys mentioned this before too, about how at one point you guys were only getting TCDs 1 to 2 days a week solely due to resources. And I think that's a difficulty that a lot of folks see out there when working in the hospital setting. So it's nice to be able to, again, just give folks a tool to be able to get that information, get it over to you guys, and then, at the end, help the patient. So no, that's great. Thank you so much for that info. Another question, one that actually came in for you, David, is you had no prior TCD experience before learning how to do TCD with the Nova Guide 2. How long did it take you before you felt comfortable performing TCDs independently? And it's a twofold question. What also surprised you about learning the whole process? So I know you spoke a bit about the training, of what that took, and it was less than a week. But what time frame did you really get like confident and comfortable? And then what kind of surprised you about the whole process?
Well, so to the first part of the question, I would say probably after the first month, I felt comfortable just going for it. The first couple of weeks, I had Andrew kind of on standby, I guess would be the best way to describe it. And I would reach out to him every once in a while, but really after that first month, I felt like, no, I have this now. I don't really need the support. And every once in a while, I can still reach out for some weird, one-off things. But I think having the support helped me get comfortable faster, because I wasn't worried day to day that something was going to happen that I couldn't handle. And so it allowed me to just kind of really dive into just getting them done and getting comfortable with the machine. Can you just repeat the second part of the question again?
Oh, of course,
Yeah.
no problem too. And just to also just to add to what you were saying too, I think that it's nice to have someone in your back pocket at all times to be able to call, especially when those weird things come up, as you even mentioned, like introverted flow, and you're like, oh, this is supposed to look like this, but I'm not seeing that. What does that look like? What is that? So it's intimidating, especially in the beginning, and I know I felt the same way. The second part of that question is, let's see, and what surprised you most about the learning process?
I will say the thing that's actually surprised me most is kind of where the machine has come. I know that's not exactly the answer to the question you asked, but the thing that's kind of surprised me most is where the machine has gone. So when we first started, it really was it'll kind of automatically find your MCA, and then everything else is a little more manual from there. You got to kind of search with the probes, which worked well, and that was good. But since then, the capabilities have increased quite a bit. Where now it'll walk vessels for you and take those pictures for you. So seeing where you guys are taking in, where both you and some of the other folks have mentioned where they want to go, where the software is going in the future, um, has kind of surprised me, because it was a perfectly functioning machine when we got it, right. Like it did the job we needed, and so seeing the drive to like still keep improving it has been
Awesome.
refreshing.
No, that's great to hear. That's great to hear. Thanks, David. And then there is a question in the chat, and I'll read it for you guys. Are there any credentialing, licensing, or site accreditation requirements that can affect who can be qualified to operate the TCD equipment or to perform the various ancillary clinical tasks, such as injecting the bubble studies? Do you guys have any thoughts or information on that?
So Maddie, I think you actually have helped guide us with that one. So I will punt that question to you.
Sounds great. I was like, I can answer for them if they'd like. So when it comes to injecting the bubbles, I'll start with the second half of that question. And then Omar, if you don't mind bringing it up again, that would be great. The second half of that question, for the bubble studies, it depends state by state who can actually inject. So I know like in the Northeast, they're a little more strict. In the Southeast, and then, over on the West Coast, so in Colorado, they're a little less strict with who actually performs the agitation and injection of the bubbles. So that varies state by state, but TCD requirements, there is no actual requirement to perform TCD. That's solely up to the hospital and the place where the TCD is actually being owned. So whoever is owning that can decide if they want someone who is, an RVT, general ultrasound, EEG, like David. So you don't have, there isn't anything mandatory. There are a few options though. So to be NVS certified or become a neurovascular sonographer, there are different places to be accredited for that specifically. To become an RVT, there's a lengthier school. They don't touch on TCD as much as NVS. So NVS is more surrounding TCD. RVT, they touch a lot of different things and then touch on TCD very, very minimally during that course. Perfect. And Eric, what types of patients do you find benefit the most from robotic TCD today? I know that you guys mentioned at South Shore, you guys are mostly focused on SAH patients. There's an SAH season, which is so crazy to say out loud.
Yeah.
But
I don't know why, really.
No one really does know why. Everybody can speculate, but no one knows. So what group do you guys feel like it benefits most? Do you feel that it's those SAH patients? I know you guys even talked about how you guys want to expand, but what group do you feel that it benefits the most right now?
So we don't deal with them quite as much as SAH or even stroke patients, but the one spot I've noticed that the robotic TCD specifically helps us the most is emboli detection, where those lengthier emboli monitoring recordings. There's previously you put the probe in like a piece of headgear and it you sit there, and if the patient moves, well, that's kind of it. You got to refind everything. That's one spot where the robotic TCD basically it's just plug and play. You put it on, it finds MCA, and then it tracks MCA for the half hour that you're monitoring that vessel. So in my experience, that's been where I've seen the most benefit.
That's great. That's great. Yeah, especially for those lengthier exams, at least we're not hovering over the patient anymore. It kind of frees up you and your back a bit. And I know there are a lot of other groups out there that are thinking of solely using this for those monitoring studies. So those lengthier studies, either the bubble studies, which are obviously shorter than emboli studies. But what's really nice is too, just to add to David what you were saying as well. With the emboli studies, we can monitor for any period of time, which is really nice, non-invasive, comfortable for the patient, and then easier for you guys too. So no, that's great. That's great. Thank you. Another question that just came in is from Josh. Do you plan on using the live streaming for your monitoring studies, so post-thrombectomy, perioperative? If so, how do you think that will impact your current service? And do you think you'll train other staff, nurses, fellows, to at least set it up, so set up the device? So to start with the first half of that question, I'm so sorry. Do you mind bringing it up again? I apologize. Do you plan on using the live streaming for your monitoring studies? So I know that you guys mentioned post-thrombectomy and perioperative. So do you plan on using NovaGuide View and that piece of the platform for that?
Yes, and we've actually talked with our interventionalists, and they would be very interested in doing the live streaming, especially for them. And we have some neuro IR fellows who would be very interested in following up and possibly doing some studies and evaluations of their own and keeping some research data in that regard. So I think that it can broaden our education and research in keeping some data for evaluating emboli, even if it doesn't create per se another ischemic event, but the detection of the emboli and the number of emboli detected. And there are so many different questions that could be asked of if it was a M1 occlusion, does that result in more emboli than a different vessel? And so it definitely could impact the service, the education, the research side of things. And we would love to train other staff, nurses, fellows, PAs. I think that it really depends on your institution and whether or not your employees are union. And so there have to be very select designations of roles and responsibilities. But I think that it would be amazing for all of our PAs to be able to do this. And I know some sites, the nurses can set up TCD machines. I think that Maddie had told me of some of their other ICUs that the nurses are part of that. But at our site, that will not be an option.
It's very, very site dependent. And we've seen that too, especially from the customer success and post-sale support side. It really depends on the environment and the workflow, and just as an overall collective, who they decide, you as a group, as the institution decide is going to be performing the studies. Absolutely. No, thanks, Krista. And a question from Lindsay: does the headpiece move around move around the head to capture the different windows, or is it able to capture all vessels in one position? Lindsay, I can answer that a little bit, and then I'd love to kick it over to you guys.
Sure.
It only captures, the robotic component captures everything in the temporal window. So the device mirrors the human hand to lock on to bilateral MCAs. And then from there, you can robotically steer it to ACAs and PCAs. I think David can probably elaborate on what he gets most of the time, from those results of, he's able to robotically steer it and kind of go from there. But David, I'd love to kick it over to you.
Sure. So I can basically, you can, like Mary said, you can get anything in the temporal window. So that would include your MCAs, your ACAs, TSCAs, and even as far back as PCA. The ones we can't get right now are your basilar and your vertical arteries. And then once you need to go down to your ICAs, those are also manual. But you are able to manipulate the probe, both positioning and then angle to pinpoint the vessels that you're looking for in that window.
Awesome. Thanks, David. A couple of other questions. So for you, Dr. Limhang, today you're primarily using robotic TCD for patients with subarachnoid hemorrhage. How has the technology readily availably changed the way your team approaches monitoring these patients? So I think we touched on that a little bit before, but if you don't mind elaborating on it, that would be great.
Yeah, I think that ultimately it's the consistency with the care we provide, and that we know the standard of care is daily TCDs to monitor for vasospasm, and then that would help prevent having to do a CTA to evaluate for vasospasm, or even more invasive, and angiography to fully evaluate and possibly treat. So naturally, TCDs are the least invasive and still very reliable mode of identifying. So I would say it's really changed in the reliability and the consistency with the care we're able to offer our patients, because otherwise, as David mentioned, in the first year or so, it was fully dependent on one sonographer's ability to stop by the hospital on her way or coming back from her primary site. And so that was not sustainable. And we now have a very fully fledged ability to provide care to our subarachnoid patients.
Oh, that's great. That's great. Thank you, Dr. Limhang. Last question, and this is for the both of you. If another hospital is considering starting or expanding a TCD program, what's the one piece of advice you give them based on your experience? Sorry to throw you guys for a loop there.
Question.
I would say think broadly. There's so many interconnected pieces of each component of growing a neurosciences institute. And so if you, like, EEG has so many players in the puzzle, and so does transcranial Doppler. So as we had mentioned, stroke patients, subarachnoid patients, each of those have their catchment of physicians and ACPs that would participate in the care of those patients. And then cardiologists also being a big component of the right-left shunt and PFO evaluation, because if they aren't going to acknowledge or endorse the use of TCDs to diagnose that, then it's not going to be useful in the microbubble studies that we had talked about, because then they would negate it and just continue with what they're doing. So you have to have a partnership with a lot of different people and really take into account the education, the open-mindedness, and the resources that you have at your site.
Yeah, tough to say better than that. It really is just you having getting buy-in and integration from the different departments in the hospital, but whether it's neurology, cardiology, to get everybody working together on the same page to meet this goal. You know, that is something we're working on here, where right now TCD is very neurology central, but we want to grow that so that everybody's getting benefit from this program, and we're all working together to increase the quality of care that we're providing.
Oh, that's wonderful. That's wonderful. Thank you both so much. There's no further questions. So again, thank you both so much for taking the time. It's always a pleasure to see you both and work with you guys. And thank you again for your time this evening. We really appreciate it. And thank you for everyone who joined. I hope you guys have a great night.
Thank you, Maddie.
Thank you.
Thanks,
Thank you
David.
for having us.
Much. Thank you. Bye, guys.
Bye.
Bye.